Thank you so much. We welcome you to this interactive instruction course on diabetic retinopathy and management. With me as faculty, I have pioneer of Indian retina, Professor H.K. Tiwari. We are privileged to have you, sir. We have Dr. Shobhit Chawla from Lucknow. Kindly keep the lights on. Who's a pen ophthalmologist, equally agile with anterior and posterior segment. We have Dr. Alok Sen from Chitrakoot, who works in a very high volume hospital. And we have to wait, as usual, for Dr. Lalit Verma, our chairman of scientific committee. This course will run under 4 sections: diabetic macular edema, proliferative diabetic retinopathy and medical treatment, surgical treatment of proliferative diabetic retinopathy, and some new additions. The course will run through a set system. I'll provide basic information on an issue, build a problem, put it to the faculty, seek their opinion, and carry the discussion, and then I'll precipitate a carry-home message. Faculty are requested to give absolutely practical answers. We will entertain questions from the delegates, but written on a piece of paper, given to me any time during the course, and I'll pass it over to the faculty. In any controversy or debate, concluding remarks will be given by Professor H.K. Tiwari. So we go ahead. Our current understanding, despite all advances, still is based on diabetic retinopathy study, diabetic retinopathy vitrectomy study, and ETDRS. DRS gave us the concept of focal burns to microaneurysm and scatter photocoagulation to rest of the retina. DRVS was conducted when no endophotocoagulation facility was available, and therefore they reported 25% no perception of light following surgery. ETDRS described practically every lesion that can be seen on diabetic retina, and this evolved the concept of focal and grid photocoagulation for diabetic macular edema. But all these studies were conducted at a point of time when there was no facility of an OCT, no anti-VEGF, no intravitreal steroids. Exact relationship of glycemia with diabetic retinopathy was not well understood. We had no concept of value of serum lipid levels. Renal pathology and its effect on diabetic retinopathy was not well understood. And on the top of all, the involvement of vitreous as a tissue in diabetes mellitus was not identified. Ajit, you are welcome. Now, ETDRS gave a definition of clinically significant macular edema, which they described as a treatable lesion wherein photocoagulation was indicated. This patient has retinal thickening at or within 500 microns of macular center. Areas of retinal thickening, at least one disc area in size, part of which is within one disc. All right. These lights to be put off. Only the stage lights.
Let the small lights be on.
Right. And then retinal hard exudates at or within 500 microns of macular center with adjacent retinal thickening. Now, as per this definition, this patient with a visual acuity of 6/6 qualifies for macular photocoagulation, but nobody will be treating this patient as on today, because ETDRS aimed at preventing moderate visual loss at the end of 5 years, but today we aim at improving visual acuity. In that connection, let us analyze briefly what are the factors which reduce visual acuity in diabetic macular edema. First is light scattering because of edematous retina. Second is impaired cell-to-cell interaction because of large cystoid spaces. And third, and the most important, is disturbed ionic balance outside and within the vessel. And this is most important, is established by the fact that even when you have sizable edema on OCT following an anti-VEGF injection, without any reduction in the size of edema, the visual acuity can improve because of establishment of correct ionic balance. Let me establish this through a case example, and then I go on to question the faculty. This patient presented to us with a visual acuity of 6/6 with microaneurysms within the foveal zone. By definition, it is CSME or severe DME as per international classification. On angiography, we see a leaking microaneurysm within the foveal area, but OCT shows a thickness of 130 microns only. Now, as per definition, it will be treatable CSME, but here The explanation is that RP cell pump is so robust that it is able to pump out all the fluid, and therefore despite a microvascular leak, patient does not show edema. Now let me run you through another case example, right and left eye of the same patient. This is early phase angiogram and this is late phase angiogram showing massive leak in the foveal area in right and left eye, but visual acuity is 6/9 despite the fact that left eye shows a huge cystoid edema and right eye is also showing cystoid spaces. Now this is again explained by the fact that though there is edema as established with OCT, the RP pump is able to pump out so much that that critical value of ionic balance is still maintained. My question to Dr. Lalit. Dr. Lalit, you are welcome. I did not introduce him. He need not be introduced, but I have to make a comment that I have yet to locate another man with such mental clarity as Lalit has. May I ask you, Lalit, that given the visual acuity of 6/9, will you like to treat this case with laser, with anti-VEGF, how much and how long?
So seeing the clinical picture as well as the angiographic picture and OCT, laser I think is out. Laser I will not advise because laser has potential to reduce the vision further and seeing the location of the leak also. However, anti-VEGF is an option. Anti-VEGF, I'll, especially in the this left eye, I will discuss with the patient and that option I will give it to him.
Shobit, will you like to treat this patient with a view that patient is symptom-free and his visual acuity is 6/9?
I would be inclined to treat the left eye. Taking in view long-time cystoid changes can lead to irreversible damage.
Let me put another case example. This patient presented to us with a visual acuity of 6/24. We injected Avastin, did a laser, and visual acuity improved to 6/9, but this kind of OCT picture persisted. We injected Avastin 4 times more, but this picture will not change. May I have comments from Dr. Alok?
Yeah. I would like to do a thorough systemic evaluation of this patient and to rule out any systemic issues which may not have been dealt with. Would like to have the fluorescent angiogram as well to see for any other treatable lesion which may have been missed. If everything has been done, then probably I will wait and watch.
The point that I wanted to bring home, that despite 4 injections, this patient has 6/9 vision and this picture persists. Is it possible, Lalit, to have permanent changes?
Yeah. OCT picture may not always correlate with visual acuity. That is one thing. And whatever injections you gave, they may not alter the structure. They may not have the potential to alter the structure. And you had already listed 3 things: the ionic balance and RP pump, which is very difficult to measure. So that is one reason this OCT picture may still remain the same in vision, because vision is centered in those last 3 layers. Where vision, if those 3 layers are functioning very well, and the ionic pump is okay, or should be okay.
No, but when a foveal detachment is there, that is a pointer towards systemic clearance.
Correct. That Alok has already said.
All right.
No. I think I would like to add one point for the benefit of the delegates here. You do not treat OCT, you treat vision. Like what he has said in the first one, that function is one thing and anatomy is another thing. I mean, if your OCT is 300 and your patient is having a vision of 6/6, I think there is no point in treating that particular patient. Yes, you need to have a very close observation on that patient. So remember, OCT and vision have to be taken side by side. I mean, with this thing, if he has got a vision of 618 or 624, whatever, then you might treat. However, if he is having a vision of 6/9 or 6/6, we'll just explain to the patient, see biochemical parameter.
Coming to that question, sir. Now that brings me to look at macular edema in a very different way. You have a vascular edema that you locate with FFA. You have a structural edema that you locate with OCT. But you have a chemical edema, that is ionic balance or functional edema, which you locate with visual acuity. My question, which I'll be directing to Dr. Tiwari, we know that there is a 12-fold increase in capillary permeability in diabetic retinopathy, and there is only a 2-fold corresponding increase in RP function. The treatments that we offer today in the form of anti-VEGF and laser only influence the capillary permeability, does not influence RP function. My question to Professor Tiwari is, that should we aggressively treat to restore function and stop as visual acuity improves, or we should go on to chase till the structure becomes normal as seen on OCT or FFA? Though you have already commented.
Same thing I would like to say, if the patient's vision has improved, even if the OCT remains a little disturbed, I will not be bothered.
Right.
The basic point is that patient's vision you have improved. Yes, there is a point that patient has to be explained that every time he has any problem or any disturbance in the vision, he has to come back to us immediately.
So carry home is that we treat the vision, not the structure. Now all we have to offer to a patient of diabetic macular edema today is laser, anti-VEGF, steroid injections and steroid implants. My personal preference always is anti-VEGF over steroids. Any faculty with a preference of steroids over anti-VEGF is the first treatment.
No, sir. I think first line of management is anti-VEGF. Okay.
Show me.
I tend to use steroid, but not steroid per se as an injection, but as a slow release implant.
Is it your
in
first
certain
choice?
situations, not in all situations, where there is...
In large majority of patients, what is your first choice? Anti-VEGF or steroid?
Large majority, it is always anti-VEGF.
Anti-VEGF.
But in
Professor Tiwari?
selected few patients, the first choice is steroid.
Professor Tiwari,
Anti-VEGF.
Dr. Alok. Once polite request to faculty, all the questions are interlinked. So when we ask you a specific question, give a pointed answer, because what you are detailing will be covered in subsequent slides. No. Sir, at the end of the session, you write it on a paper, and we don't want you to say a point. You serve a question, we will supply the answer. Now, before we go on to debate between this common thing, Avastin and Lucentis, let me elaborate a little how anti-VEGF work. Most people believe and also write in papers that I gave Avastin and edema disappeared next day. Anti-VEGF have no mechanism to reduce edema. Anti-VEGF can only reduce capillary leak and consequently improve tissue perfusion both at the level of choroid and retina. Edema is taken care by RP cell, and depending upon the strength of RP pump, edema can be less or edema can be more in one or the other eye. This is picture of a diffuse edema before Avastin. You see absolutely silent choroid, no perfusion in the choroid, and this is picture at 24 hours after injection of Avastin. This is another convincing picture. Whole circulation is directed to this neovascular front. There is no filling elsewhere, and at 48 hours it appears almost a normal retinal circulation except this NVE. This is another revealing picture, and through these pictures we establish that anti-VEGF help by improving tissue perfusion, not by reducing edema, which is a common misconcept. My question to Dr. Alok is that when we know that laser has a lasting effect, do you treat every case with anti-VEGF first and then apply laser?
Yes, I do treat most of my patients with anti-VEGF first, and after 1 or 2 getting the edema reduced, then we apply lasers so that we get a more uniform sort of laser. So we do try to...
What is your view?
I do the same. I will not keep injecting. Like in ARMD is a totally different disease where we keep injecting. But in DME, I agree with Alok that we give injections and then do a more definite treatment in the form of laser.
Shobit, how many injections you will be giving before doing laser? I have a patient on follow-up who has received 64 injections of Avastin.
On an average, I'll see the response after the first injection. If I feel the response is adequate, I'll go ahead with laser. Maximum I would be up till initially 3 injections.
So consensus
when I
is
switch modality.
Consensus is that 1 injection by majority of faculty, up to 3 by Dr. Shobit. Lalit, you have already said that you inject once or twice, but do you treat still some cases without anti-VEGF with laser only?
Yes, sir. Yes, sir. There are situations where OCT, my limit of OCT will be around 300. And if it is the leakage, we pay attention to both leakage. If the leakage in the safe area, that means after that black circle, then I will, first line of treatment maybe laser itself.
Now let's ask Dronacharya. When do you stop injections and when do we start laser? Professor Tiwari, please.
Look, first and foremost is after giving 1 injection, when there are patients on fluorescein angiography, you decide, and on OCT you see there is edema. Now you see in the fluorescein angiography there are some lasering area possible. I mean some of the areas you can laser. So what you do is you give 1 injection of anti-VEGF to this particular patient. wait for about 2 weeks, and then all the, like Dr. Lalita said, extrafoveal areas can be lasered in this particular patient.
Okay.
However, what he has said is quite right. We generally give up to 3 injections. If 3 injections had not helped the patient, or the thing has remained the same, then you can go on to treat and extend or PRN or whatever you want to do.
Right. Now, one question that I direct to Dr. Lalit, respecting his mental clarity, many times it happens we have given anti-VEGF, we have done laser, edema subsided and patient was maintained well for maybe 1 year or maybe 1.5 years. There is no traction and the laser is adequate, there is no more space for laser. How do you handle these cases, that is recurrent non-tractional edema which was stabilized?
In patients who have non-tractional edema, I would like to repeat an angiogram in such patients. Meaning thereby, what is the cause? You see, traction has been ruled out by OCT, but we would like to do an angiogram if to see specifically, because angiogram will reveal wealth of information. There could be, revealing CNP areas very close, which could be cause of decreased vision, or there could be, other changes also. So angiography I like to advise.
Right. This is a case exactly demonstrating what Lalit said. This was absolutely well lasered and it stabilized, and these 2 large areas of capillary drop were located on angiography, repeat angiography, and the patient was subsequently photocoagulated. So the message is first anti-VEGF and then laser. Now, ETDRS described 2 kinds of macular edema, focal and diffuse, based on angiographic findings, and accordingly they described 2 kinds of photocoagulation, focal is specifically applied to microaneurysms, and grid, that is in a C pattern, applied to whole of the posterior pole in diffuse edema. Now, focal is classically described as an edema wherein you see hard exudates, generally in the form of a ring, and in the center of hard exudates there are a group of leaking microaneurysms. But if you look at right eye, it gives you the picture of diffuse leak, and in left eye there is no leak in the center of ring, the leak is actually from an upper vessel. Similarly, there can be cases that show you succinate rings, but no sooner you attempt to take a photograph, already posterior pole is completely filled up. These 3 leading studies have questioned the terminology of focal and diffuse edema, and based on these 3 studies, these conclusions were drawn that microaneurysms and retinal thickening and exudates do not correspond always, and therefore direct closure of microaneurysms as advised in focal coagulation is questionable. They further established that there is not necessarily an increase in the number or leak from microaneurysms with increasing thickening of retina, and good percentage of cases can show focal leaks on FFA and diffuse thickening on OCT, and in DRCR net almost 50 to 80% of cases were treated without FFA. To add to that, in ETDRS, 3 to 5 treatments were applied over 1 to 3 years to all cases that were initially treated with focal photocoagulation, and the tool used was contact lens examination and not FFA, which will only identify areas of thickened retina, not additional or newly formed microaneurysms. That means, in a sense, in ETDRS, all cases that were said to be subjected to focal photocoagulation at the end were converted into grid photocoagulation. Given this background, in DRCR net they said that irrespective of the type of edema, whether it is focal or so-called diffuse edema, mild macular grid photocoagulation is done, and they published their results which were comparable to ETDRS. My question to Dr. Lalit again is that in view of all this background that I have given, do you consider it's necessary to do FFA and OCT in all cases, since we have to do generally a grid photocoagulation treating thickened areas of retina, so why not go ahead as such?
FFA, I said, is maybe because of to pick up ischemia and all, but it is not mandatory.
Be close to mic.
Frankly speaking, it's not mandatory because we have to see thickened areas which we can identify on slit lamp.
So you agree that you can go ahead for first photocoagulation yes. without FFA?
It is mostly indirect kind of treatment. We don't want to hit directly at the microneedle.
Right. So the brilliant view of our chairman scientific committee is that the focal and grid photocoagulation distinction is no longer observed. It is generally on the side of grid photocoagulation that we are treating macular edema with. Professor Tiwari, as I said, is Dronacharya, old-timer who must have done thousands of focal and grid photocoagulation. Do you retain that concept or you have changed?
No, I have to be very frank with you. I, for one, don't do any grids nowadays. Let me be very honest. Yes, focals I definitely do whenever there are areas. But I was doing a lot of grids. Let me be very honest with you. Like initially when the TDRS came, we were doing a lot of grids. Then they modified C and all that of things. But recently, we have stopped doing grids. We do believe in doing a focal photocoagulation.
But do you simultaneously treat areas of thickened retina?
Pardon me?
When you are doing a focal photocoagulation specifically over microaneurysms and you see areas of thickened retina also, do you photocoagulate them?
Sure.
So that amounts to grid, sir. Okay.
No, grid is entirely different.
It's not classical grid. What I am saying that
Yeah.
amounts to a large scatter photocoagulation over posterior pole. Now all cases do not. Yep. It's neither classical focal. It's neither classical grid. It is something in between that he is advising. Now Alok, all cases do not respond very well to laser and also anti-VEGF. Any leading features that will actually explain such poor response?
Yeah, actually the presence of, as shown here, the presence of macular ischemia or a subfoveal hard exudate plaque, these patients usually they have poor response to any kind of treatment you give.
So that brings us to discuss at length role of lipid exudates and ischemia. Now we'll discuss ischemia first. In my personal observation, the ischemia as seen on fundus fluorescent angiography does not always correspond with vision. There are patients who show classical macular ischemia on FFA and have a visual acuity of 612, 618 or even 6.9. And also, these cases, if they have already been lasered, angiography may not give you any useful information. Shobhit, given this background, what is your tool for saying that this is a case of macular ischemia?
A thorough fluorescein angiography.
It may not always describe the right things. Lalit, can OCT be used with some advantage if angiography is uninformative?
You can. Apart from the fact that OCT angio is now available, but OCT can, because if you see OCT in arterial kind of block, ischemia means there is some arterial insufficiency. It could have a hyper-reflective zone, or sometimes in, let's say, thinning may occur. It may help you. It can be a guide. It may not be. Usually 100% is FA.
So my impression out of the two faculty is that it's not easy to settle by any method that this is a case of macular ischemia because visual acuity can be misleading. A new technique has evolved wherein the principle is that erythrocytes can be traced with 500 to 30 to 590 nanometer wavelength. They say that normal velocity of erythrocyte is 20 milliseconds. In pathological states, it slows down to 2 millimeters per second. And thus you can picture microvessels with a digital camera. This technique is known as retinal functional imaging. This is macula of the same eye with FFA, which shows ischemia, and this is macula of the same eye with retinal functional imaging, which does not show ischemia. So perhaps we have to have advanced investigative techniques to confidently comment on ischemia.
Again, these articles have come out in press, but the point is, I think the machine is not commercially available.
It's not easily available.
It's not easily available or commercially available?
No, it's not easily available. It's short of production or whatever, they are giving it to neurosurgery department more.
Neurosurgery, yes.
In USA it is available and they are now building the different layers of the retinal.
Okay.
Of the retinal capillary network.
Yeah.
So that's what he's referring to, and
I am
it
saying
is not
that
available in India.
We
definitely.
require to have better tools
Yeah,
to be
yeah.
confident about ischemia. Now, with current available methods, Shobhit, when you have diagnosed a case as macular ischemia, do you treat this edema or you don't?
I surely treat it with anti-VEGFs to start with.
Lalit, do you feel that there is a risk of increasing ischemia with anti-VEGF as was the popular concept?
Not now, sir. Initially, I also had issues because of their properties, but no, it does not. I have personally done it. I agree with Shobhit, you should freely give anti-VEGF.
Dr. Tiwari, do you second that we should confidently give anti-VEGF in macular ischemia?
To be very frank, not before I read your article, not that I agree with you a lot of times.
But do you agree?
You have beautifully shown that it doesn't make a difference at all.
Do you agree now?
Yes, I agree now.
So consensus is that ischemia is not a contraindication for anti-VEGF injection. Now, this has been too hyped a thing for my understanding. It is known that lipids are toxic to capillary endothelium. They cause loss of pericytes. They induce inflammation. They increase serum viscosity, and they derange the fibrinolytic system. And with this, systemic lipid-lowering drugs were started at a great gusto all across this country in patients of diabetic macular edema with any kinds of hard exudates, right? But several studies that were conducted, they finally concluded that it does not alter the response to laser, it does not influence the recurrence rate, there is no association in retinopathy up to 4 years duration, and no visual improvement is found despite disappearance of the hard exudates. This is one of our follow-up patients who was strictly maintained on UKPDS norms for 18 months. The hard exudates have remarkably disappeared, but patient did not have any improvement in visual acuity. My question to Professor Tiwari is that do you believe that a high circulating serum lipid is responsible for hard exudates?
Well, it is a very difficult question to answer, but I will say that in such patients, when you get a serum cholesterol done or lipids done, their level is high.
Sure. Is it that all patients with hard exudates over macula will have a dangerously high serum lipid level?
No, not all patients, but some patients, the correlate is there.
Okay.
The association is quite weak actually. Frankly speaking, most
Yeah.
of them will not.
Now, I want to take faculty poll. How many cases you have seen wherein the hard exudates disappeared on lowering the serum lipid, starting from Dr. Lalit?
Sir, hard exudates do disappear, but they take months and months. And it is not necessary that all hard exudates disappearance will parallel the visual acuity improvement.
Alok?
Sir, they do disappear, but it's difficult to know whether it is because of lipid lowering drug or because
That's
you
the
do
point,
add
or it's the natural history.
natural, and you are giving treatment as well. So
Yeah.
you are treating these eyes as well.
Sir?
They definitely disappear. There is no second doubt, no doubt about it. But vision does not improve.
Shobit?
I agree, totally agree with what Dr. Tiwari said, that they
So
do disappear.
We have, yeah, Ajit.
Like the picture which is shown here, what happens to the photoreceptors, and if it is sufficiently length of time it is deposited and photoreceptors are damaged, how can you expect a visual recovery?
No, I am not
after
saying.
disappearance?
I am not saying that. I said they do disappear, but the vision does not improve.
Yeah,
That's it.
that's what we need to
So-
tell the audience. It do
That's what I
disappear,
said.
but the timing
Okay.
of
Ajit, that's
Okay,
what
okay.
Ajit, that's what I said.
So this faculty gives the information that they do not strongly believe in the concept of treating high serum lipid levels in a patient. Now they say that the visual outcome is always poor in diffuse edema. With I disagree. And even if you read ETDRS carefully, the visual acuity improvement has been shown in diffuse edema also. Whatever it is, do you differentially treat diffuse edema than so-called focal edema, Alok?
No, sir. I would still give anti-VEGFs followed by lasers.
All right.
Only.
Now there are three things which are popular. Some people say first obtain a good systemic control 3 to 6 months. Then they say inject anti-VEGF and do laser. Others say inject triamcinolone and do laser. Does it respond to steroid better than focal edema, and is steroid treatment better than laser for diffuse edema, Dr. Lalit?
First line still remains anti-VEGF, sir.
You will not give steroids.
Not as first line.
Shobit?
I'm a little more aggressive, I combine both. I give a steroid implant along with anti-VEGF at the first go, or I give a anti-VEGF and follow it up with a steroid implant to have a sustained effect.
All right, your first choice will be steroid. Now, when I published that paper with which Professor Tiwari agreed with great difficulty, I mentioned in that all body tissues react to inflammation by generalized exudation from capillaries, which responds to steroids. And inflammation is an essential pathological factor in causation of diabetic macular edema and retinopathy today. So my concept was, is it that the so-called diffuse edema has more element of inflammation than microangiopathy as contrasted to focal edema, and thus these are two manifestations two different manifestations of the disease of diabetic retinopathy, and therefore steroids provide a better response. May I see comments from Professor Tiwari?
The basic point is that there is an element of inflammation in diabetic retinopathy, there is no doubt about it. However, those people who are promoting the steroid injections like Orthodox people, now in the recent EURETINA meeting, they presented article where they said that all those inflammatory interleukins and all that are increased in this. So they are promoting that it should be the first line of treatment.
All right. So consensus is that steroid is the first drug choice.
No. I never said that. My choice is not steroid at all.
Okay.
Even the European Union and FDA, they have given a conditional approval.
All right.
In patients who are pseudophakic or
Yes.
about to become pseudophakic.
Let's have view. Anti-VEGF first choice.
Yes.
Or Alok? Anti-VEGF first
Anti-VEGF
choice.
first choice.
Sir?
Anti-VEGF.
Diffuse edema combination.
Combination. All right. Okay. Okay. We summarize that visual acuity. We summarize that visual acuity should be considered for starting and terminating the treatment. As said by Professor Tiwari, we treat vision, not OCT and FFA. Focal and diffuse forms need to be defined better. Modified macular grid laser, Professor Tiwari pattern is the preferred pattern. It's not necessary to treat microaneurysms directly. Areas of thickened retina should be treated. FFA may not be necessary, insufficient to diagnose ischemia. RFI may prove a better tool. Ischemia is not a contraindication for anti-VEGF, and role of lipid-lowering drugs is uncertain. Now we come to this popular investigation, OCT, which gives two kinds of information. One is quantitative information, that is thickness of the retina, and other is qualitative information, that is structure of retina and vitreoretinal interface. Dr. Shobhit, for my purpose, quantitative information, that is thickness of macula, really does not matter in deciding the treatment. What use you make of quantitative information?
Not that much use for initiating treatment. Only thing, I'm a little more inclined to initially use steroids if I find a large underlying serous detachment with cystoid changes.
Lalit, do you pay any importance to underlying serous
The height
detachment?
of OCT does not matter, and it is mostly to impress the patient that it has come from here.